محمد يعطيك العافية.
هذا دكتور ناصر، الله يعافيك سيدي.
جاهز الأمور عندك سيدي؟
اه سيدي تمام جاهز.
الله يعطيك العافية.
اعمل
طيب
شير
الله
سكرين.
يعطيك العافية، احنا جاهزين إن شاء الله نبلش.
تمام ان شاء الله.
طيب مرحب فيكم جميعا في لقائنا العلمي المستمر. آه ولقائنا اليوم كما أعلنا هو محاضرة عنوان بوين انفكشن talking about septic arthritis and osteomyelitis. محاضرة راح يكون إن شاء الله دكتور محمد عليمات، أستاذ جراحة العظام والمفاصل في مركز فرح. دكتور محمد تفضل يعطيك العافية سيدي.
السلام عليكم، يعطيك العافيه شباب، الله يمسيكم بالخير. آه اليوم ان شاء الله نحكي عن موضوع البون انفكشنز ان جنرال، سيبتيك ارثرايتس، اوستيوميلايتس، كمان شوي راح نحكي بشكل مختصر عن البيوجينيك مايوسايتس. هذا الموضوع بصراحه كثير اكستنسيف، اوكي، very important for every orthopedic practitioner. آه very extensive. راح نحاول بصراحه اكون هيك concise قد ما بقدر. we'll start with septic arthritis. We'll talk about the definition, the pathogenesis, clinical presentation, the treatment, the sequelae, and the complications. What's the definition of septic arthritis? From the name, arthritis is a joint inflammation secondary to an infectious etiology, usually bacterial, but sometimes can be fungal, mycobacterial, viral, or other uncommon pathogens. As we learn in medicine, when time equals muscle, in septic arthritis, time equal cartilage and equal joint destruction. The pathogenesis, how the bacteria can get into the joint. It's either one of three ways. The most common one is through the blood, the presence of bacteremia. The second way is by direct invasion, by direct penetrating trauma to the joint. And the third way is by an adjacent infection, especially from an adjacent osteomyelitis. Risk factors usually presence of recent upper respiratory tract infections, otitis media, sinusitis, skin infection, whatever, all of these can cause bacteremia and seeding of bacteria into the joint. Invasive procedures such as in young age pediatrics, okay, with umbilical catheterization or IV catheterization. Another risk factors huge in general are immunodeficiency, sickle cell disease, varicella infection, malnutrition, preceding trauma, anything that can decrease, let's say, the host defenses, okay, for bacterial infection. What happens exactly after bacteria seeding to the infection? When bacteria gets into the infection, this will result in an inflammatory reaction that is driven by the local macrophages, the monocytes, the synovial cells. Now, this will cause an acute inflammatory response with the release of too many cytokines, and this will result in releasing of also proteolytic enzymes, lysosomal enzymes. Now, these enzymes will work on destruction of the cartilage subunits, specifically the proteoglycan loss, and this will lead to recruitment also of further immune cells and immune defenses. Now, with the presence of these leukocytes and this inflammatory reaction, also there will be joint effusion and increase in the hydrostatic pressure within the joint, and this will also lead to decrease the blood supply and further causing cartilage damage. Cartilage damage actually starts within 8 hours of the infectious process. Now, this important idea بصراحة شباب to keep in mind is that with young ages, the growth plate will not form a good barrier between the epiphyseal and the metaphyseal part. In the young ages, below 18 months, or some literature mentioned below 24 months, there's a transphyseal circulation between the metaphyseal and the epiphyseal part that can spread the infection from the metaphyseal part to the epiphyseal and to the joint, and vice versa. It can also spread the infection from the joint into the epiphyseal part and into the metaphyseal part. In older ages, above 18 months, the epiphyseal part will have its own separate blood supply, and the growth plate will work as a good barrier that resists infection transmission through this way. Now, what is the causative agent Staph aureus is the main criminal. Staph aureus is the main and the most common cause of septic arthritis in all age groups. Now, Staph aureus have a wide variety of virulence and genetic composition. It is studied the genetic composition of Staph aureus, and it's found that genetic composition of Staph aureus is related to the degree of immune response, degree of disease presentation, especially for this species who carries these genes, the fibronectin B and PVL, Bantam, Valentine, Leucidine. Staph aureus carries these genes will results in a more inflammatory, more aggressive inflammatory response and more aggressive complications. Both of these genes can be found in MRSA and methicillin susceptible Staph aureus, but it's more in MRSA. Another thing also is recently studied is the CNA, which is a gene that's responsible for the ability of the bacteria to bind to collagen in what is known as a collagen hug. So CNA positive Staph aureus also results in a more aggressive, let's say in infection and more aggressive inflammatory response. Now, this collagen hug or CNA positive is just like if you see in this picture, this is a very tight looking mechanism, but at the molecular levels, okay, this forms a very tight bond with the collagen, and even makes the bacteria more difficult to eradicate from a mechanical, even from a mechanical point of view. Another second most common is the group A streptococcus. Usually in school ages, lethal it can result in more fulminant and bad infection. Group A streptococcus. Usually those kids have more aggressive clinical picture. In those infected with the group A streptococcus, you have to look to the patient as a whole, because sometimes we are focusing on a joint infection while the patient should be assessed even primarily for possible shock, for a possible deterioration of different systems, the renal system and other systems. Okay, interesting figure is that in the Center of Disease Control in the United States reported in 2002 around 9,000 cases, almost 9,000 cases of streptococcal infection. Imagine that 1,350 ended in death. So we have to look at the general physiological state of the children. This table on the right is I recruited from the American Academy of Orthopedic Surgeons. You can see these are the most common microorganisms and at different age groups. And on all of these, Staph aureus is the most common microorganism. Please be attention to the second group between 3 months and 5 years, where Klebsiella kingi is the second microorganism in this entity and in this age group. Klebsiella kingi is some sort of atypical infection, but now some literatures considered it to be the most common microorganism in this age group, in less than 5 years. But why is this consideration came recently? Because of increased awareness of Klebsiella kingi. Klebsiella kingi is a slow-growing gram-negative microorganism. Recently, there is an improvement in specimen handling and in culture techniques. This resulted in a higher detection of this microorganism. One of the reported case series of Klebsiella kingi infection, imagine that for the 6 cases that were detected for Klebsiella kingi, when the culture was done immediately on blood bottle or chocolate agar in the theater, the success rate of diagnosis of this infection was 5 out of 6 cases, while in the routine laboratory process, only 1 out of 6 cases were diagnosed. And for this infection, Rocephin, ceftriaxone, trimethoprim is the, or beta-lactam antibiotic are the choices for management. We have also the Neisseria gonorrhea and the TB. These are some of the demographic data for septic arthritis. Usually it takes place around the age of 2 years. It's more in the males than females. It is in the right more than the left. In regard to the joints most commonly involved, some figures mentioning the knee as being the most commonly involved, and some mentioning that the hip and the knee are almost equally affected. Now, it all starts with clinical evaluation. Clinical evaluation is very important in bone infection, because too many cases you might not find the typical picture that you are looking for. So please be careful. History starts with pain, general, let's say a recent upper respiratory tract infection, past history of the patient, presence of any cause for immunodeficiency, any cause to decrease his immune response, physical examination, including fever, the ill appearance, the irritability, limited joint mobility, and for the hip, the classical Faber position, flexion, abduction, external rotation to maximize the joint space in a trial to decrease the pain. Clinical judgment is very important and crucial, especially in neonates. Why? Because neonates will not elicit the full toxic clinical picture. Sometimes the clinical picture is just let's say irritability, vomiting. Sometimes you find hypothermia instead of hyperthermia. So in this poor feeding, so in this age group, you should maintain a high index of suspicion. When we are talking about septic arthritis, more than one differential comes into our mind. One of these is osteomyelitis. So how can I differentiate between septic arthritis and osteomyelitis? Usually in septic arthritis, the pain is elicited by passive range of motion. So if I'm trying to move a hip for a child with a septic hip, usually the child will refuse any trial to do a passive range of motion, while usually in osteomyelitis you still can do a passive range of motion. Another thing is that differentiation from irritable hip. Irritable hip or transient synovitis is a very important differential diagnosis for septic arthritis, and it is not uncommon to see irritable hip every now and then in the seeking medical help in the emergency department. How to differentiate? More than one thing to differentiate. Let's start by the simplest is the history and the clinical presentation. Usually the age for septic arthritis, as we said, is around 2 years, okay, but irritable hip is uncommon to be seen in this age group. Usually irritable hip is seen around the age of 6, while septic hip comes in much younger age. As we said, the clinical presentation of septic hip is usually more toxic, more aggressive, and for the symptoms, usually it resolves spontaneously in irritable hip within 48 to 72 hours, while in septic hip, the symptoms, of course, will exacerbate. Of course, we don't have to wait all this time because if we are suspecting a septic hip, we should be, let's say, quickly diagnosing and quickly managing our patient. For that reason, Kocher criteria was developed. Kocher criteria, it's composed of 4 predictors for infection for septic arthritis. These are fever more than 38.5, ESR more than 40, and white BCs count more than 12,000, and failure to bear weight on the affected limb. I know most of you know this criteria. When one of these predictors is involved, there is the risk of 3%, risk of septic arthritis 3%. When a 2 of these predictors, it's 40%. With 3, it's 93%. With 4, it's almost 99%. Now, is Kocher criteria can be applied outside the hip? This originally was developed to diagnose hip septic arthritis. Application outside the hip was a matter of debate, and there was no consensus, while some authors accepted the Kocher criteria to be used outside the hip. Others found that when this criteria was applied outside the hip, there was a risk of 52% of missing a diagnosis of septic need, for example. So upon that, some modification were done by Caird et al. They added the CRP level as the fifth predictor, and they emphasizes the significance of fever among the other as being the most important and the best predictor among the other elements of Kocher criteria. Lohmann and co-workers conducted a study that they tried to test the sensitivity of Kocher criteria for the diagnosis, even in hips, suspected septic hip. They found that the numbers did not exceed 59%, even with all the four criteria, all the four predictors were positive. So they came to the conclusion with advice to keep a low threshold for doing ultrasound and erythrocentesis. As we said, fever is the best predictor. Fever, then CRP, then ESR, then refusal to bear weight, and finally the white BC's count. After emphasizing these things, we can come to an exclusion, is that predictors, we should not entirely depend on predictors for the diagnosis. Predictors we should use to guide our observation, to guide our decision, either to go for observation or doing aspiration. And please keep a low threshold to do aspiration and analysis. And predictors also guides our management either to admit or to do close follow-up for the patient. And again, please keep a low threshold for admission. As this is from one of the papers, you can see that diseases do not treat box all the time. In these hospitals, these are case series where you can see in hospital when they reported just 54% incidence of fever, they reported a white BC's count more than 10,000 just in 72%, other hospitals 73%. So this by this we can make the conclusion of keep a good index of suspicion when you are diagnosing septic arthritis. Investigations, we'll talk about investigations for bone infection in general, including the septic and osteomyelitis. We'll discuss the investigations in a more detailed way, at the beginning of the lecture. CBC, as we said, it could be elevated in around 70% septic arthritis. In osteomyelitis, it's up to 35%, may show leukocytosis. We have CRP, which is the most important laboratory test, the ESR, blood cultures, plain radiographs, ultrasound, aspiration, either ultrasound-guided aspiration or fluoroscopic-guided aspiration, along with the gram stain and analysis and culture, and procalcitonin and interleukin-6. The first few labs we'll talk about in the upcoming slides. For the last two, the procalcitonin and the interleukin-6, they are showing a promising numbers regarding the possible sensitivity. And it's believed that interleukin-6 is the cytokine that's responsible for stimulating the liver to produce C-reactive proteins and other important, let's say, acute phase reactant proteins. Interleukin-6 showed a higher sensitivity in neonatal septic arthritis with earlier detection, but unfortunately there is no standardization and a higher cost and limited availability. CRP, what is CRP? CRP, C-reactive protein, is acute phase reactant protein. Why it is named CRP? This first was studied in patients with pneumonia. It found that this protein reacts with the pneumococcal C polysaccharide in the plasma. It reacts with the pneumococcal C polysaccharide in the plasma in patients with pneumonia. That's why it was called a C-reactive protein. It's the most sensitive, it's the most reliable clinical laboratory test. In inciting infection, CRP levels increase 1,000 folds within 6 hours of onset and reach a peak within 36 to 50 hours. it is detectable within 6 to 8 hours of the infection. The doubling time is 8 hours. An important piece of information about CRP is that CRP has a short half-life of 24 hours, and there is a constant clearance of the body. Why is this piece of information is important? This piece of information is important because if I have infection and I'm dealing with this infection in the proper way and treating my patient, definitely CRP will get low and decreased soon as it is rapidly cleared and constantly cleared from the body. So, resolution, going back to normal level within 7 days following an effective treatment. Recent literature reports a peak at day 1 and normalization at day 11. It also has another diagnostic rule, diagnostic and prognostic rule. Some literature found that if by the 3rd day I found that the CRP level is 1.5 the admission value, this means almost 6-folds increased risk of possibility of combined septic arthritis and osteomyelitis. So, and this will alter my options for management and my management plan. It also, CRP guides transition or shifting from IV to oral therapy. It is elevated with surgery or trauma, TB plate being the most common surgery that will increase the CRP level. After that, the TPN nail. After that, the conservative method. But even with the trauma, it will not reach a clinically significant elevation in the value. Another factor is the ESR. ESR is the rate at which red blood cells fall through the plasma. It is measured by millimeter during an hour. Fibrinogen level is a key factor in ESR value and may continue to slowly rise when the child is starting to improve. The value slowly returns to normal over several weeks following effective treatment in uncomplicated cases. But unfortunately, ESR is greatly influenced by the number, size, and the shape of RBCs, as well as the other plasma constituents. And there is significant variation in measured levels, which may be misleading. It should not be significantly elevated in response to trauma. The ultimate value of the ESR is typically at the decision point to terminate antibiotic therapy because by the point that I reached a normal ESR level, almost all the other parameters have already been normalized and the infectious process almost have been eradicated. Culture of the blood and local tissue. We mainly do culture for aerobic microorganisms. Others should be considered in immunosuppressed and penetrating injury or when there is a failure of management. It's not that much sensitive. Blood cultures are positive only in 20 to 40% of the time. In another papers, 21 to 55% remains culture negative. So sometimes we might need a more sensitive diagnostic test along with atypical microorganism, and this should be considered and kept in mind. Kingella infection, as we said, synovial fluid should be cultured in aerobic blood culture bottle in addition to agar plates in order to increase the detection rate. Radiographs. Radiographs rule is to exclude other causes such as tumor, fracture, avascular necrosis, and identify sometimes deep soft tissue, and this may be the first finding to be noticed. Synovial fluid aspiration, this is the gold standard for the diagnosis. For the synovial fluid examination or aspiration, there is a macroscopic assessment and there is a microscopic assessment. Regarding the macroscopic assessment, we look at the gross appearance, at the volume. Regarding the volume, usually it is less than 3.5 millimeter. In septic, you find more than 3.5 millimeter. Regarding the clarity, and normally the synovial fluid is transparent. In septic, it is opaque. The color usually it's clear normally, while in septic arthritis, there is yellow or greenish discoloration, pulsy discoloration. Regarding the viscosity, it is highly viscous, while in septic this viscosity is usually lost or variable. How to judge regarding the viscosity? We can put a drop of the synovial fluid between our fingers, try to stretch it, or we can drop from the syringe and look for the string that is formed. Usually in normal synovial fluid, this string length is around 4 to 6 centimeters. Now, this regard to the macroscopic or gross assessment. Regarding the microscopic assessment, usually these numbers are classically believed to be associated with septic arthritis. Is a white PC count of more than 50,000 with more than 90% polymorphonuclear neutrophils and glucose level of 50 milligram per deciliter less than the serum glucose level, and elevated protein secondary to presence of bacteria in the joint. Now, more recent literatures concentrate and focus more on the polymorphonuclear percentage as being more sensitive than the total white PC counts. High lactic acid level, okay, when this is done, due to gram-positive oxide or gram-negative rods, and it is well known that it is difficult or not easy to culture bacteria from synovial fluid because joint fluid inhibits the growth of certain bacteria. Culture is positive in 30 to 70%, and other figures around 50 to 80%. That's why some recent modalities of diagnostic tests such as nucleic acid amplification, PCR, that can give you results, even faster results within hours, and it may be used to differentiate between methicillin-sensitive Staph aureus or methicillin-resistant Staph aureus and diagnose Kingella and other atypical infections. Ultrasound, I know this is not our field, but it's good to have an idea about ultrasound findings. Okay, usually if you look at this figure, you can see that this is the epiphyseal area, this is the metaphyseal area, and this is the capsule. You notice, please, the area of the neck, the junction between metaphyseal and epiphyseal area. The bone shape is a concave shape, and the capsule follows the shape of the bone. Please notice on the right side, this is the normal right hip, and this is the septic or the left hip with effusion. The right side, you can see this is the bony appearance. This is the capsule, and notice, please, the capsule taking the concave shape. When the presence of effusion, the capsule will be stretched to take a convex shape instead of the convex shape. MRI. What is the significance of MRI in septic arthritis? It is particularly significant when I suspect the presence of association between septic arthritis and osteomyelitis, that this septic joint is secondary to an adjacent osteomyelitis. And when this actually detected, this will change my management plan and my assessment of the children and even the prognosis and the expected outcome. For that, criteria was developed by Rosenfield, where if you have 3 or more of these points, you should go for MRI for possible adjacent osteomyelitis. Age more than or equal 4, CRP more than 13.8, duration more than 3 days, platelet count less than 314, and absolute neutrophil count more than 8,600 cells per milliliter. Now, regarding the Rosenfield criteria, again, there is no consensus. Some literature found that there is a high false positive rate, so you suspect that this is have adjacent osteomyelitis. You go for MRI, and you detect that this is just an septic arthritis, not associated with an adjacent infection. But keep in mind, especially in young age groups, to do MRI. It's keep a low threshold again for doing an MRI, but it is important not to let the MRI delays your management. By any means, the MRI should not delay the management in patients with septic arthritis. This to the left is a kid that was treated for septic arthritis, but 2 days after the first incision and drainage, the child failed to achieve such dramatic clinical improvement. So an MRI was done, and it revealed an adjacent osteomyelitis and pyogenic myositis bacterial infection or intramuscular abscess. This on the right is one of the cases that was treated by our colleagues. Sorry, I can't play video. Okay, so this is for a kid who was less than almost one and few months age, and was transferred to the pediatric team for septic arthritis. And fortunately, they detected an adjacent proximal femur osteomyelitis and was treated upon that. Nuclear imaging is rarely used, low sensitivity and specificity. You know the classical three phases of nuclear imaging: the blood flow, the immediate phase, the blood pooling in the soft tissue phase, 15 minutes after injecting with radioactive material, and the third phase is the delayed or the skeletal phase after 2 to 3 hours and up to 24 hours. Septic arthritis is uncommonly diagnosed with nuclear imaging, and in osteomyelitis, there is increase and uptake in all phases compared with cellulitis and pyogenic myositis, where you found the maybe the increased uptake in the first and the second phase. Treatment. Treatment is two parts: the antibiotic part and the surgical part. The antibiotic therapy, we start usually with empirical antibiotic selection for septic arthritis, and is also similar for cases of osteomyelitis. We will talk about the choices of antibiotic in the next slide. We should usually, the most commonly used antibiotics, the big synovial concentration of the commonly used antibiotics equals or more than 60% of the serum level, and this will give us an adequate dose or bactericidal dose. For the empirical antibiotic recommendations by American Academy of Orthopedic less than 1 month ampicillin, sulbactam, gentamicin, 1 to 3 months vancomycin and ceftriaxone. Pediatric and adolescents, okay, cefazolin or cefuroxime, clindamycin when there is a high MRSA rate, and when I suspect or there is a resistance for clindamycin, the choice is vancomycin. Still, what we use, which is first generation cephalosporin, is still valid options for too many microorganisms. Now, after beginning with IV antibiotic, we'll go for the surgical management, okay, by incision and drainage, and finally we go to transition or shifting from parenteral to oral treatment. We'll come to the surgical part after a while, but as we're talking about antibiotic therapy, I will talk about when to shift from parenteral to oral treatment. Now, the European Society for Pediatric Infectious Diseases believes that we can shift when the kid is afebrile or there is a dramatic decrease in the temperature for 24 to 48 hours, and the child shows a good clinical improvement of symptoms with a good range of motion and subsidence of the swelling, and the C-reactive protein is 30 to 50% from the maximum value. Paloketalin, one the literature mentioned, a near normal CRP level should be obtained, and no signs of complications such as bacterial spread to other areas or DVT, and absence of virulent pathogens, especially MRSA or PVL positive staph. Usually in uncomplicated cases, total period duration of management is 2 to 3 weeks. Some target CSR normalization, some target CRP normalization. We should keep in mind that we might need a prolonged treatment in PVL positive staph aureus in a poor response and newborns and young infants. Now, regarding the surgical treatments, septic arthritis is one of the few orthopedic emergencies. a satisfactory clinical results obtained with earlier intervention. So those who were treated in less than 4 days of symptoms have achieved a very good response, but this does not give us an excuse to delay the management. We should treat septic arthritis as soon as possible. This is an joint emergency, as we said earlier in the lecture. Time equal cartilage, time equal joints. More and more delay will result in more and more cartilage destruction. What will happen if the management is delayed? There might be a fibrinous, loculation, and Pannus formation. Pannus is a fibrovascular tissue that might be a nidus for the infection. So there is a wide variety of, let's say, surgical strategies and surgical ways of management. Okay, some believes in aspiration and lavage. There is also a method of repeated aspiration, okay, and this repeated aspiration is well documented for the knee and shoulder. It is studied in the hip in a series of 28 patients. 24 of the 28 have achieved a cure rate with frequency of 3.6 aspiration. 75% of those patients resumed working after 24 hours. But even if this mentioned, okay, in the literature, it should not be our first way of management. You can rely on these sometimes when you have some difficult scenarios, when the patient cannot be anesthetized or high risk, or for a reason or another, the surgery might be delayed. So you can go for aspiration, lavage, and repeated aspiration. What's gaining popularity recently actually is arthroscopy. Arthroscopy have the advantage of providing a comprehensive visualization of all the aspects of the joint, and it can assess the severity of the infectious process, and it can detect any fibrinous aggregates, any advanced synovitis, along with being, let's say, surgery that's minimally invasive. It can result in an earlier functional rehabilitation. In a series of 75 patients, there was a 91% cure rate. Open revision was needed only in 4%. Another series of 11 patients, okay, who underwent open arthrotomy, 0 out of 11 needed revision with arthroscopy. Sorry, this study was comparing two group patients. 11 of those went into arthroscopic drainage. 13 went into an open arthrotomy. In the arthroscopic group, 0 out of 11 needed revision. In the open arthrotomy group, 5 out of 13 needed a revision surgery. Open arthrotomy is an emergency procedure whenever there is a gram stain positive or more than 50,000 white PCs count in synovial fluid aspiration, and when there is a high suspicion regardless of the finding. Journal et al. In one of the papers mentioned that if the symptoms are more than 5 days, CRP more than 10 milligram per deciliter, more than 15,000 neutrophils, and the SR more than 50, an immediate arthrotomy should be performed. Now, these are photos of an arthroscopic drainage for a child who underwent an open arthrotomy, okay, but after 3 days, the patient fails to achieve clinical improvement. You can see in the suprapatellar pouch on the on picture A the presence of these fibrinous aggregates and the synovitis, and patient underwent, okay, arthroscopic management. And after that, the patient showed a good and dramatic improvement. To summarize, this is from this algorithm is from the American Academy of Orthopedic Surgeons. Whenever you have a clinical suspicions of septic arthritis with fever and ability to bear weight, peripheral range of motion, the classical presentation, or a newborn with irritability, malaise, vomiting, or refusal to eat, you should go for a good physical assessment, do radiographs, do labs. If you found 3 out of 4 criteria for the hip, or CRP level more than 20 milligram per liter or ASR more than 20 millimeter per hour for all other joints, if you found these findings, you should go for joint aspiration. You go for gram stain culturing and or PCR. If clinical suspicions of concomitant septic arthritis and osteomyelitis, we should do an urgent MRI, and we should immediately start after getting the samples with empirical antibiotic and arrange for surgical irrigation and debridement. If I do not achieve these 3 out of 4 criteria or this CRP level or ESR level, I should go for ultrasound, MRI. If this was positive for joint effusion, go for joint aspiration, do the gram stain. If it's positive gram stain or clinical suspicion of septic arthritis, start empirical therapy and surgical drainage. If the ultrasound and MRI are negative for joint effusion, you should monitor the patient clinically and you should follow the fever, the CRP, the white BCs, and reevaluate other potential differential diagnosis. Complications are bad in septic arthritis in the form of end-stage arthritis, osteonecrosis, joint stiffness, persistent infection, dislocation. Please don't discharge your patient from the clinic early. At least 1 to 2 years follow-up is recommended for patients with septic arthritis to monitor for any limb length discrepancy, for any deformity. In general, whenever you are managing your patient early, you and your patient will end up in a happy face. If the management is delayed more than 5 days, okay, so here comes the complications window. Prognosis is generally well in isolated and well-managed septic arthritis. Anatomic location is significantly affect the outcome for proximal femur and the hip or the associated osteomyelitis. Usually have a less favorable prognosis. Younger ages have less favorable prognosis, and delayed management, of course, have a less favorable prognosis. What is close to the joint is the muscles. Pyomyositis is bacterial infection of the muscles. Primary or secondary to penetrating injury or local spread from an adjacent infection. Usually, pyomyositis affects single muscles, and the most commonly involved muscle is the quadriceps. After that, we have the gluteal muscles and the iliopsoas muscle. Please, whenever you have a suspicion of septic arthritis and you didn't find, and you did aspiration, or you didn't find the patient is as a septic, or you did not label the patient as a septic arthritis patient, keep in mind that this might be pyogenic myositis. And for this specific diagnosis, again, if this was treated early, you can solve the problem of your patients just with IV antibiotic. It all starts with the invasive stage, where the bacteria invading the muscle, and after that we have the purulent stage, 10 to 21 days from the symptoms, and we have after that the late stage, where the collection and the pus can spread into the soft tissue, adjacent soft tissue. This is a muscle infection, but this does not mean that creatinine kinase should be high. Creatinine kinase might be normal or minimally elevated in pyogenic myositis. The best diagnostic test is MRI. Management is usually antibiotics if the diagnosis was initiated early in the invasive stage, and this stage surgery may be avoided. Usually the average duration of management is 4 weeks, with a duration ranging from 2 to 8 weeks. Surgery is reserved for patients with a collection. You can manage this with CT-guided drainage, which is a good option, or surgical, and surgical drainage is preserved for a septic child with a multiple small loculated abscesses. Complications: multifocal involvement, sepsis, shock, multi-organ failure, and mortality. Again and again, streptococcal is a bad infection. Keep in mind. The second part of the lecture is about osteomyelitis. What is the definition of osteomyelitis? Osteomyelitis is inflammation of bone and or bone marrow, usually due to infection. Types: either acute osteomyelitis, subacute osteomyelitis, chronic osteomyelitis, and there is an entity called chronic recurrent multifocal osteomyelitis, CRMO. For the acute osteomyelitis, it has a variable incidence and variable prevalence according to regions. Usually affects the metaphyseal part. The long bones are affected in 75% of the cases. The lower limbs more than the upper limbs. The femur is the most common involved bone. After that, the tibia. After that, the fibula. To less extent, we have the humerus and the radius. The pathophysiology. Regarding the pathophysiology for acute osteomyelitis, it is usually frequently referred to as acute hematologic osteomyelitis because the blood, let's say, bloodstream is the most common source, or the hematogenous spirit is the most common source of infection. The bacteria will move along these nutrient vessels until it comes to the end arterioles. These end arterioles are small and they are connected with these venous sinusoids. Now, this anatomical configuration will form a loop. Presence of such loop will result in slow and turbulent blood flow. Now, this sluggish blood flow will allows the bacteria, whenever it's present in the blood, to localize, increase the risk of bacterial localization in this area. Another thing is in children is that they have a wider endothelial gaps. Now, this wider endothelial gaps and this sluggish and turbulent blood flow, all of these factors along with other factors will help the bacteria to migrate into the extravascular space. Now, presence of the bacteria in the extravascular space does not mean that infection definitely will happen. Osteomyelitis, that definitely will happen. There is another risk factors. One of these risk factors is the presence of some sort of compromised bone in a form of necrosis or trauma. When there is surface antigen, collagen 1, the endotoxins that is released by the bacteria that suppress the immune response, and even some parts of the growth plates, such as the primary spongiosa, which is acellular. Okay, all these are multiple factors that contribute to the pathophysiology of osteomyelitis. Now, bacterial presence, bacterial seeding will trigger the local macrophages, the monocytes, to phagocytose the bacteria, and this will result in metabolic derangements and release of many cytokines, prostaglandins. All this acute phase response will increase the local physiological response and metabolic alterations, and increase blood supply to the area, and systemic features such as fever, lethargy, leukocytosis, and as we said, increased vascular permeability, and will stimulate the liver to release multiple acute phase reactants. Prostaglandin actually is an important factor that increased 30 times the amount that's released by the normal bone. In some animal experiments, it's found that NSAIDs using ibuprofen helped decreasing bone resorption and sequestration. I didn't read anything, okay, regarding this kind of management in humans, but it's worth mentioning. CRP, as we said, is a very important acute phase reactant with multiple functions as opsonization and activation of the complement pathway, and trigger also release of another immune complexes. Keep in mind the issue of the transphysial artery, the transphysial blood supply. This is especially important for the humerus and femur in the young children because of the risk of transmitting this infection to the joint and vice versa. Another way, as we said, of getting osteomyelitis is local invasion from an adjacent infection or direct inoculation from penetrating trauma, such as foot puncture or open fractures. Now, the classification, we know the classical Cerny-Madar classification, but it has a limited application. This classification has limited application in pediatric osteomyelitis, and these classification are based on age groups and severity. But Cerny-Madar classification have two items: the location of the infection and the general status or the host or patient, let's say, immune status. For the location for type 1 medullary osteomyelitis, limited to the medullary canal, or type 2 superficial. It is infection that is limited to the external part of the bone, does not permeate the cortex. Type 3 is a permeative, stable infection. Infection penetrates the cortex of the bone, but usually it's axially stable. And for type 4 is permeative, unstable infection throughout the bone in a segmental fashion with axial instability. And regarding the host or patient factors, type A is a normal physiological host. Type B is compromised host, either in a systemic way or on a localized way, or in a combined systemic and localized way. And type C, when the management is worse than the disease itself. Now, these are different age groups and the management option for each age group. Again, you can see that Staph aureus is almost the most common, microorganism in different age groups. Kingi is gaining popularity in infantile and early childhood. Now, classification of infection by age. Classification of infection by age, we start with neonatal age. Usually, neonatal osteomyelitis is considered in children with age of 2 to 8 weeks. It can be comes in two clinical presentations or two ways. Either when the newborn is kept admitted, in the hospital, or acquired from the community when usually after normal vaginal delivery, or sometimes cesarean section, when the child goes to the external environment and comes back to the hospital. Now, what's important in these age groups is that the child sometimes will not show the practitioner the classical picture of infection. There is lack of typical features, fever and irritability. Sometimes this is just confined to temperature instability, abdominal distension, feeding, poor feeding, and presentation is tachycardia or tachypnea. So please, in this age group, keep always a high index of suspicion and keep a low threshold to do aspiration of the bone and the joint. This should be performed performed liberally, meaning that keep a low threshold to go for bone and joint aspiration. In those who are admitted to in an ICU, who get usual infection from the hospital, keep in mind that they might have a multifocal osteomyelitis or a multifocal septic arthritis, and a historical way of bilateral hip aspiration was practiced widely and still in some areas practiced. So please keep in mind that this age group will not show you the classical presentation of osteomyelitis. You might only find swelling within the limb in a certain area. After that, with infantile and earlier childhood, 3 to 36 months, at this age group, the child start to lose the maternal immunity and increasing exposure to other organisms such as Shigella, different species of Streptococcus, Meningococcus, Haemophilus influenza B, especially in unvaccinated, and the serum antibody level, the bactericide antibody levels for this microorganisms, it develops with time. Drainage and aspiration of septic arthritis is strongly endorsed early in life, less than 18 months. Staph aureus, again, is the most common microorganism in this age group. Childhood, 3 to 12 years, Staph aureus 80 to 90% of the microorganisms, and Strep pyogenes 10%. With 36 months average age, the badly infected age group is usually around the 8 years of age. Those come with the severe infection and multi-system dysfunction. Good news is that first generation cephalosporins still are viable and very good options for management in these age groups. adolescents against Staph aureus and Streptococcus, but in the first world country, they have the Neisseria gonorrhea. I think we don't see this microorganism too much because at that age, they started the sexual activity, and keep in mind that this might result in a disseminated infection. Investigations, as we talked about, these are almost the same investigations: CBC, CRP, ESR, blood cultures, and plain radiographs. For the plain radiographs, please, when you look at the plain radiograph, don't look at the bony part only. Keep in mind that there is a bony part and there is a soft tissue part. As you can see at the lateral side of the ankle, you can see at this radiograph, if the bone appears normal and there is no bony changes, okay, but the lateral side, you can see abundance of tissue. This indicates deep soft tissue swelling. This patient, when he did an MRI, he was diagnosed with fibular osteomyelitis. Again, radiographs are important in diagnosing tumor, fracture, AVN, and other differential diagnoses. And if we want to wait to have changes on radiograph, we have to wait 10 to 14 days, and at least 30 to 50% loss of mineral density should be there in order to find bony changes on radiograph. The management, it is again the same as in septic arthritis. We have two parts of the management. We have the antibiotic part and we have the surgical part. The IV antibiotic part is strongly guided by the recommendations of the infectious disease specialist, and this highly dependent on the prevalence of community-acquired MRSA. Dose for osteomyelitis is usually higher, okay, 2 to 3 times the standard dose. Parenteral therapy is continued until an appropriate clinical and laboratory response is obtained, and then oral antibiotic therapy can be started. Duration for IV antibiotic is variable between 3 and 14 days. This is strongly guided by the CRP level, the improvement in the clinical picture, the improvement in fever. Now, transitioning to oral antibiotic, it was found in the literature that early transition to oral antibiotic is a safe practice. But when can I shift into oral antibiotic? As we said, number one, when there is a clinical and laboratory improvement. Number two, I should have an effective oral agent that is tolerated by the child. But if I want to continue the management of the patient as outpatient, and I didn't find the oral agent that is appropriate for this child, what can I do? There is an option that's called OPAT. OPAT is outpatient parenteral antibiotic therapy. Outpatient parenteral antibiotic therapy is a valid choice where the child presents for a certain clinic when he gets his dose of IV antibiotic, and in studies there was minor complications that's limited to the drug reaction itself. Number three is very important to keep in mind, is that the social and the family history should allow for a good compliance. So if you found a child with who is most likely will be under a poor compliance, it's safer to keep the patient in hospital. Total duration of antibiotic, there is no standardization, variable, and this strongly or largely dependent on the severity of the infection and the response of the patient. Usually 4 to 8 weeks in general. In uncomplicated cases, usually 23 days, mentioned in some literature, was the mean time for cure. ESR normalization is the target with a value of less than 15 millimeter per hour. If this was not reached by 4 weeks, you can go for another 4 weeks of antibiotics. If, again, you fail to achieve, or the patient failed to achieve a normal ESR level, by 12 weeks, we should go for MRI. Regarding the surgical management, again, there is a difference, or there is no consensus regarding the timing, the extent, and the necessity because of lack of clear and specific indications for surgery. For some patients, for some series, a patient went for, let's say, an aggressive surgical intervention with the drainage of both sides of the infection and the curettage and drilling and fenestration of the bone. Despite all of this management, 17% of chronicity was obtained. Other centers basing the decision on factors indicate failure of antibiotic therapy. So whenever you have subperiosteal or interosseous abscess or metaphyseal lytic lesion or a limited clinical or laboratory response, you should go for surgical management. Another authors recommend surgical intervention when the proximal femur is involved, even when a lack of abscess and in earlier disease. This is maybe in some centers because of the horrific complications of the proximal femur osteomyelitis. What are the outcomes after acute osteomyelitis? The most feared complication is chronic infection. Chronic infection is strongly correlated with antibiotic durations. And I found in some papers that the correlation between the duration of antibiotic and the chronicity, when antibiotics were used for less than 3 weeks, there was a risk of 19%. And when it was used for more than 3 weeks, the risk of chronic infection development was 2%. AVN of the proximal humerus and the femur, this is strongly associated with delayed recognition, a presence of concomitant septic arthritis, and inadequate decompression of contiguous osteomyelitis. Growth disturbance, high severity of illness at initial presentation, is a risk factor for growth disturbance. Growth disturbance or physial growth plate being affected might cause either a limb length discrepancy or deformity, depend on the percentage or degree of involvement of the growth plate. Now, sometimes you might find in the X-rays a small physial tinting. And now with this central small physial tinting is common in those patients. And in literature, they mentioned a minimal impact on long-term complications. Pathological fracture, greater prevalence with subperiosteal abscess and large circumferential size abscess, and when there is a sharp zone of dimension enhancement. So in those patients, you have to think about the rehabilitation protocol. Sometimes you have to keep the patient with on a protected weight peering in those risky patients. DVT and PE, this is a life-threatening and part of disseminated staphylococcal infection. The genetic factors found in children and bacteria, in bacteria, especially the PVL, Banton, Valentine, Leukocidine, and MSSA, and aggressive infection and longer hospital stay. Sometimes the patient might end up with a multi-system involvement, and of course, the antibiotic-related reactions should be also kept in mind. The second entity of osteomyelitis is subacute osteomyelitis. This is more difficult to diagnose. Why? Because onset is usually insidious, gradual, and there is a mild symptoms, and these symptoms might be present for more than 2 weeks before seeking medical attention. Laboratory studies may be normal or only mildly elevated. Radiographic features many times suggest a benign or malignant skeletal neoplasia. In 50% of cases in one series, in this series, the correct diagnosis took on average 3 to 5 months in 2 separate reports. And its increasing incidence compared with acute hematogenous osteomyelitis. Now, in subacute osteomyelitis, the diaphyseal, the epiphyseal are more commonly involved compared to the metaphyseal involvement in acute hematogenous osteomyelitis with older age compared to acute hematogenous osteomyelitis. Cultures are positive only in 29 to 60%. Pathophysiology is secondary to altered host pathogens relationship. It's not fully understood, but it may be characterized by a decreased bacterial virulence and an increased host resistance, and some cases are thought to occur secondary to an inadequately or partially treated acute osteomyelitis following the administration of antibiotic for other infections. One report found that 40% of children with subacute osteomyelitis had recently received antibiotic for other infection, including tonsillitis, acne, or tooth abscess, compared with only 5% of children with acute osteomyelitis. Primary acute osteomyelitis, those children without any antecedent or precedent illness of or treatment. Now, knowledge of the pathophysiology of this condition, as we said, it is limited. But again, as we said, it's believed that only a localized inflammatory response develops. And this creates a local bone destruction that may or may not stimulate a sclerotic or periosteal reaction through a combination of pressure atrophy and inflammatory granulation tissue. This is a classification developed for subacute osteomyelitis. Gledhill classification initially and expanded by Robert into 6 types. Type 1, 2, 3, 4, 5, and 6. In type 1, it's either A or B. It looks very similar to Brodys abscess, the classical Brodys abscess. A without sclerotic margin, B with sclerotic margin. Type 2, there's a metaphyseal perforation. And type 2 usually it might look like osteosarcoma. For type 3, there is localized diaphyseal lesion with periosteal reaction and may be misdiagnosed or misinterpreted as osteoid osteoma. Okay. We have type 4. It is a diaphyseal lesion with subperiosteal new bone formation, just like on your skin appearance. So type 4 might be diagnosed as Ewing sarcoma. Type 5, when there's an epiphyseal involvement, and type 6 is vertebral discitis or vertebral osteomyelitis. Evaluation and treatment. Again, a complete laboratory and radiological evaluation. Multidisciplinary approach. You need a radiologist for the differential diagnosis. You need a bone oncologist for possible biopsy in the controversial cases. You need a pathologist, microbiologist for possibility of atypical microorganisms. Most authors prefer surgical management for these cases, but in the literature, few cases reported for successful treatment with only antibiotic for 6 weeks. Outcome, most resolve with appropriate treatment and staphylococcal for 6 weeks. There is an entity which is primary sclerosing osteomyelitis, which results in a prolonged course with intermittent symptoms and maybe up to years. Long follow-up is recommended usually in bone infection cases. Finally, the chronic osteomyelitis. What is chronic osteomyelitis? Is defined as the presence of ongoing bone infection for longer than 1 month. Some places mentioned 6 weeks. In the presence of devitalized bone. Usually, chronic osteomyelitis is preceded by acute osteomyelitis. Is a consequence of acute osteomyelitis that may lead to extensive bone necrosis and formation of sequestrum. Sequestrum is a dead bone, devitalized. Sequestrum is a devitalized dead bone. And ultimately, this might cause a segmental bone defect. How to prevent chronic osteomyelitis? The early diagnosis of acute osteomyelitis and prompt initiation of antibiotic therapy with an appropriate duration of treatment. Chronic osteomyelitis is more common in developing countries. Staph aureus is the most common microorganism. Most common site of involvement for chronic osteomyelitis is the tibia because of limited vascularity of this bone and further compromised by the extensive periosteal stripping that occurs in advanced osteomyelitis. Most children who have chronic osteomyelitis have undergone many surgical interventions for acute osteomyelitis. As we said again, in children with acute osteomyelitis, there is a metaphyseal infection. The metaphyseal cortex is thin. The periosteum is loosely bound at this area. Now this infection will invade the periosteum and will result in eruption into the subperiosteal space and travels down around the diaphyseal area, and this will deprive the bone from its blood supply. This will result in a dead bone secondary to deprivation of the blood supply to the bone, and this will result in granulation tissue. which also retard healing and harbor bacteria, because neither antibodies nor antibiotics can nor antibiotics can adequately penetrate these tissues. Certain bacteria, particularly Staph aureus, adhere to the bone by expressing receptors for component of bone matrix and demonstrating intracellular survival within osteoblast. So intracellular survival within osteoblast is a recent concept that was studied, which might explain the persistence of infection in chronic osteomyelitis. So after that, a new bone formation will be formed in response to the formation of this sequestrated bone and the periosteal elevation. Now, classification by Sternum-Madar classification is stage 4B, where there is a diffuse osteomyelitis and host who is compromised either locally or systemically. There is another classification for chronic osteomyelitis, which is Jones and Jones and colleagues proposed. The classification include 3 main types: the A, B, and C type. Now, the A is the Brodie's abscess, the B is the sequestrum and the involucrum, and B is subdivided or subclassified into B1, where there is a localized cortical sequestrum. B2, when the involucrum, the new bone, start to form. So we have in B2 sequestrum with normal structural involucrum. And B3, we have a sequestrum with a sclerotic involucrum, and type 4 sequestrum without structural involucrum. So this B4 means a limited ability of the bone or of the limb to form a new bone. Now, as we go more advanced in the stage, the eradication of infection is actually more and more difficult, because usually in stage maybe 1 or 2, removal of the sequestrum is likely to result in resolution of infection with a normal involucrum, whereas eradication is more difficult in the advanced stage. And type C is when the whole bone is sclerotic. Sometimes you find the suffix P or D, this for proximal or distal physial involvement. Again, evaluation starts with the history, looking for any past history of acute osteomyelitis, doing the laboratory test, doing the cultures. Sinus culture in the literature is mentioned as a valid choice, okay, by some authors, okay, but it needs, let's say, a proper, let's say, sterilization technique or cleaning technique. But of course, the cultures that obtained intraop, okay, are more and more accurate. High quality X-rays is mandatory to evaluate for presence of sequestrum, involucrum, bone defects, and AVN. MRI with and without contrast differentiate areas of bone infarction and sequestrum formation from areas of active osteomyelitis and abscess formation, but it has the drawback of inability to distinguish clearly between acute and chronic osteomyelitis. It's also difficult to interpret the significance of extensive marrow signal abnormalities associated with advanced stages. The CT scan might be more informative in terms of identifying the sequestrated bone. Always in these cases, keep tumor in mind, such as Ewing osteosarcoma. Treatment, again, antibiotic therapy and surgical therapy. Antibiotic therapy always require consultation with an infectious disease specialist. Rifampin is favored in this patient as a supplemental to the first line because it is intraleukocytic bactericidal action. IV antibiotics for 4 to 6 weeks initially, and management with antibiotic therapy might be extended to 6 or 9 months. Effective treatment requires both surgical and medical intervention. Some patients, some children have reported cases of complete recovery with antibiotic only, but this may be true when the disease is discovered very early in the chronic phase, and when there is a dramatic good early response with antibiotic therapy. Please keep in mind that almost many of those patients will require medical and surgical management. Debridement surgery is the foundation of osteomyelitis treatment. the major goal is to remove the sequestrum, any abscess cavities, any granulation tissue that might carry bacteria, and prevent the circulation from delivering antibiotic to the infected tissue. Multiple procedures usually is needed to achieve this goal. Difficulty lies in determining how extensive and debridement should be, but sufficient infected bone and soft tissue must be resected to allow antibiotic therapy, again, as we said, to complete the process. Madar co-workers appropriately suggested that debridement should be direct, atraumatic, and executed with reconstruction in mind. Why? Because sometimes you end up with, let's say, a soft tissue loss, secondary to excising the whole infected tissue, and a large part or large segment of the bone is excised. So keep the reconstruction of the bone and soft tissue in mind. In general, as we said, two important things: you should reach a viable cancellous bleeding, the classic paprika sign, and the external stabilization is used whenever threatened skeletal stability. Dead space might be managed by either vascularized tissue and by vascularized tissue and try to perform a complete wound closure whenever it's possible. You can use implantable and bioabsorbable antibiotic delivery method that will release antibiotic locally in a very high concentration, sometimes reach 200 times the serum level, and this will be eluted up to 6 weeks. Another alternative method is using antibiotic pump infusion. Periosteum is important for the healing process, so this assists by the presence of involucrum, which takes 2 to 8 months to form. In the presence of generous involucrum, most children regenerate adequate diaphyseal new bone and avoid the need for bone grafting and other complex reconstructive procedure. Early debridement of the sequestrum is not thought to be harmful to the subsequent formation of the involucrum. Reconstructive procedures are multiple choices. You can go for open bone grafting, tibial fibrillar synostosis, vascularized fibular graft, soft tissue transfer with muscle flaps. Bifocal methods of bone transport using Elizarov method is very effective way of managing these cases and these scenarios. It's believed that distraction osteogenesis increases the blood flow by 3 to 100 times in the extremity, and this will enhance the local tissue levels of antibiotics. These are different way of reconstructing the bone defect. Okay, you can see this is a vascularized fibular transfer that hypertrophied and get to the size of the normal bone with time. You can see this is a muscular technique where a bone cement that is impregnated with antibiotic can be used to fill the defect after excising this sclerotic dead bone. And this is distraction osteogenesis, where you can see reconstruction of the defected bone segment. Complications: recurrence of the disease within 2 years was found in 20 to 30%, despite treatment with surgical debridement, appropriate antibiotics. More aggressive debridements, such as that performed with Elizarov method and oblique wire bone transport, reported to yield better results with 80 to 100% good or excellent outcomes. Most of the complication with chronic osteomyelitis is reported in the treatment of chronic osteomyelitis related to the reconstructive procedures, such as osteopenia, joint stiffness, angular deformities, non-union, proximal tibial joint dislocation, site infection. And the final topic is chronic recurrent multifocal osteomyelitis. Now, this is a diagnosis of exclusion. It usually found in patients with another chronic autoimmune or systemic inflammatory disorder, such as rheumatoid arthritis, inflammatory bowel disease, or psoriasis. The clinical symptoms and signs might be a localized redness, pain, and swelling of insidious onset and spontaneous regression, minimal functional impairment during the episodes. The pathophysiology is unknown. Some hypotheses mentioning autoimmune pathophysiology or unrecognized cause of infection. Usually, this is a diagnosis of exclusion with more than 3 months, and biopsy showed chronic inflammation and failure to achieve an infectious agent, and managed with NSAID, cortisone, interferon gamma bisphosphonate. Okay, this table summarizes the different diagnoses, differential diagnosis, and presentation for each. So please notice that in osteomyelitis you might not have fever. Usually it's present in septic arthritis and pyogenic myositis. It's maybe absent or low in discitis and transient synovascular decay. Usually it's absent or low grade. At the onset for septic arthritis and pyogenic myositis, the septic is the most acute onset of limping and non-weight bearing. To a less extent is this in pyogenic myositis and osteomyelitis. The systemic features are more obvious in pyogenic myositis and septic arthritis, are less in osteomyelitis, and the patient usually systemically will be well in transient synovitis. So finally, this curve I like to mention every now and then for my colleagues, for my friends. Okay, this curve is known as the Dunning-Kruger effect or curve. This draws the relationship between the amount, the level of knowledge, and the confidence level. Actually, when anybody starts in any field, he has no knowledge in that field. Okay, and he have a very low confidence. Many who start practicing in certain field, when they have some amount of knowledge, they start to have a rapidly peaking level of confidence. But with time, when you know more and more, you discover that you don't know more and more things. Okay, so with knowing more, the confidence level drop, and by knowing more and more, this confidence level starts to improve. But even for the most expert levels, they don't reach the level of confidence for the juniors. Okay, so please keep in mind that diseases does not always come in the typical picture, in the typical presentation that you might suspect. Please keep a high index of suspicion. Whenever you suspect something, go and follow your suspicion and try to reach diagnosis. This lecture was prepared from too many sources. These are part of the sources. Forgive me for being a long presentation. Thank you all for listening. And again, sorry for being a long lecture. I tried to make it as short as I can.
دكتور محمد، الله يعطيك ألف عافية.
الله يعافيك سيدي أبو ركان.
ومحاضراتك يعني دائما أو زي دائما هي طبعا تعودنا عليها، فيها معلومات مفيدة جدا. الإطالة طبعا أكيد مفيدة، فيها كثير إجابات لكثير شغلات بمر فيها الواحد. بصراحة الموضوع موضوع كومن، والموضوع موضوع لازم يعني الزملاء يعرفوا فيه ويعرفوا فيه منيح. فأكيد أنت ما قصرت بصراحة، فالله يعطيك ألف ألف عافية.
العفو سيدي، كل الشكر سيدي أبو ركان.
وبالعكس احنا حابين تكون انت يعني مثال للزملاء ايضا الاخصائيين لما يقدموا محاضرات، يدخلوا قد ما يقدروا يعني يقدموا الاكستنسيف نولج اللي ممكن تجاوب كثير وتحكي كثير، واللي يعني الزملاء كمان المقيمين يستفيدوا منها اكثر شيء ممكن. because what you highlight is what they concentrate on when they study. So you've highlighted يعني many points that are valid and important, and I think يعني this is what we aim يعني for our residents، اللي هو النولج اللي بيحتاجوها بحياتهم. والله يعطيك العافية.
Yes, thank you sir. والله سيدي نحاول نعطي بصراحة practical knowledge as much as we can. يعني بصراحة يعني many of us يعني faces difficult scenarios, sometimes too many questions. Why I got مثلا negative culture? Why is this infection are being يعني more and more diagnosed? فبصراحة يعني as far as we know that we don't know. فتhank you سيدي يعني your words is highly appreciated. يعني always give us بصراحة يعني هيك a plus of يعني positive energy، وإن شاء الله نكون هيك فدنا الشباب وقدمنا لهم شيء.
الله يعطيك العافية. لا ما شاء الله ما شاء الله.
يعطيك العافية دكتور محمد، محاضرة رائعة.
الله يعافيك سيدي، يعطيك العافية دكتور ناصر.
الله يعطيك العافية. ما بعرف إذا
الله
حدا
يجزاك.
عنده زملاء أي سؤال؟ المحاضرة كانت يعني شاملة جدا لكل شيء. إذا في أي سؤال أكيد دكتور محمد جاهز لأي شيء. يبدو أنه ما في أسئلة. طيب، إذا الأمور واضحة تماما إن شاء الله عند الشباب، أي استفسار أكيد راح يتوجه لدكتور محمد على الخاص،
أكيد سيدي،
وراح
أي شيء
ييسر معكم
يعني
أكيد.
you are welcome at any time.
هذا تعليق بسيط بجوز، يعني المحاضرة أعطت أو قدمت أجوبة أكثر مما أثارت أسئلة، فكمان هذا إشي يعني يشكر عليه الدكتور محمد يعني.
العفو سيدي، الله يبارك فيك.
أكيد سيدي، صحيح. كانت تقدم إجابات لتساؤلات كثير. طيب، إذا هيك نوصل لنهاية لقائنا اليوم إن شاء الله، ونذكركم بلقائنا غدا إن شاء الله، محاضرة عن الإكس فيكس بتكون إن شاء الله مع دكتور فهد السرحان. يعطيكم العافية جميعا، إلى لقاء الغد إن شاء الله.
يعطيك العافية سيدي.